Hey everybody, welcome back to the channel. My name is Reed, and on today's video, the topic of discussion is going to be ventricular fibrillation. If you want to have access to these strips, this document that I'm going to go over right here, you can download it from the description below. So you can follow along and make your own notes. And so ventricular fibrillation is we'll say it is a rhythm that is not compatible with life, right? Meaning that it doesn't allow for the heart to work effectively, and so you will not have effective blood flow, and so this person will be in cardiac arrest. And so let's talk a little bit about this rhythm. This will be quick and easy. Notice here that we've got 3 different rhythm strips, right? This is rhythm strip number 1, rhythm strip number 2, rhythm strip number 3. So these are all their own rhythms. This is typically not found on an ECG because, one, if somebody goes into a ventricular fibrillation, or for short VFib, if they go into that rhythm, then they will be in cardiac arrest. We'll be doing chest compressions. We're not going to be putting on all these stickers. And so usually we get it on like a rhythm, like we just have someone hooked up to a monitor, right? And so we see it. And so a couple things about VFib that I want to talk about. So some criteria here. For one, why is it not compatible with life? Because the rate is going to be above 300 beats per minute. And so while sometimes VFib can be an organized rhythm, the rate is so fast that the ventricles, if they are squeezing at a rate of 300 beats per minute or more, essentially they're going to be fibrillating. That rate is going to essentially create a fibrillation, right? It's just going to be quivering, right? Kind of think of it like a quiver, where it's not going to be able to be effectively squeezing. Imagine trying to squeeze your hands 300 times a minute. The squeeze would be very minimal, if anything at all. And so the ventricles just kind of quiver, right? They just kind of quiver. And so that's why this is not a rhythm that's compatible with life. So the rate is over 300 beats per minute, and it is polymorphic. Okay? So polymorphic means that you will not see the same shape of the QRS every single time. Okay? Sometimes that polymorphic can appear organized, right? But it's going too fast to where it's now a fibrillation. And so let's take a look at these strips. You can see here on strip number 1 that we'll be looking through, we have a very disorganized rhythm, right? We've kind of got these wide complex QRSs with some polymorphic beats. Some of these are premature ventricular contractions, maybe a normal QRS right here. And then all of a sudden you see things kind of organized right here, and from here on we have this fast rate. You can see it's initiated by, there's a QRS there, and then what appears to be some type of premature ventricular contraction that kicks off this beat. And the premature ventricular contraction occurs right after this QRS, and it kicks off this beat, this rhythm. Notice for 1, this is a polymorphic. This is a polymorphic rhythm. And how do I measure the rate on these? Well, what I'll do is I will find like the tip of a QRS complex, like this one. I'll find the tip of the next one. And if those tips are less than 5 millimeters in width, we know that 5 millimeters is 300 beats per minute. So if it's more narrow together than that, then we've got a tachycardia that is above 300 beats per minute. And so you see this one's kind of, it almost looks like torsades. Some of you guys have heard about torsades, but this is a polymorphic rhythm that's got a rate that is greater than 300 beats per minute, right? You can even see on this strip, this one lands on a solid line. The one before it is less than 5 millimeters. So this is greater than 300 beats per minute. What are some of the causes of VFib, right? Usually there has to be some type of event that causes a depolarization, repolarization abnormality, okay? So you could maybe have a long QT interval so that maybe the next QRS lands on that QT interval, right? That would cause depolarization in a moment when we are still repolarizing, and that ventricular myocardium could be susceptible. You could have causes such as ischemia that cause for these reentry circuits because of some scarring injury that is maybe here. There's a reentry circuit that develops. You could have congenital abnormalities. You could have metabolic abnormalities, right? Electrolyte abnormalities that predispose you to these events. You could have multiple of these things together. So VFib, there's typically a cause of some sort, and so and usually there's more than one cause that when you add together puts someone at risk for a VFib. So let's look at strip number 2 here. So strip number 2, you can see we've got a normal QRS complex that's tacking away. It seems to be kind of regular, a little bit irregular. And then you see we have this PVC that occurs on the ST segment, right? Here's my, if I could draw what my T wave would look like. And I've got this PVC, this wide complex beat that lands right on it, right? So there is a, what we would call R, we would call it an R on T phenomenon, where essentially a wide complex QRS, a PVC, lands on the T wave of the previous beat. And so this is an example of depolarization during a time of susceptibility when not all of the myocardium has repolarized. And so there could be a reentry circuit that is caused. And so then you see the genesis of this narrow complex, or excuse me, this rapid complex rhythm. It is polymorphic. It is polymorphic. And if you look at the rate, you can see that the QRS complexes are less than 5 millimeters from each other. That means that my rate is greater than 300 beats per minute. So you put those two things together, and that is ventricular fibrillation, or VFib for short. Let's look at our last strip here, strip number 3. You see the kind of the same type of rhythm here. We've got these QRS complexes that are going along, and then you have another insult, right? That insult is this wide complex beat that comes early, and it comes where? On top of the T wave. So we have another R on T type phenomenon, and it kicks off another narrow, in the sense that they're not narrow complex, right? The complex themselves are wide, but you can see the rate is well above 300 beats per minute. It's also polymorphic. And so this is ventricular fibrillation. And you can see it kind of can deteriorate into a less organized, and it can sometimes organize. When you see that it organizes, a lot of times it has to do with a reentry circuit, right? So say this is this red right here is some type of scarring. So sometimes you can actually have a reentry circuit that it kind of can rotate along its own axis. So it can kind of start like this, and then you see it kind of rotate along its own axis. And then it'll kind of rotate back. So it can kind of flatten out in different planes. So you can almost see it change the axis of re-entry. So that's why sometimes you can see what it appears to be organized, but if you look closely, it's greater than 300 beats per minute. That's V-fib. Couple things to remember. This is not compatible with life. These people you'll do CPR on. Treatment is going to be defibrillation electrically, right? Sometimes you can use antiarrhythmics to help, depending on the etiology of V-fib. But ultimately, what you need to recognize is just that this really rapid polymorphic rhythm that is greater than 300 beats per minute, and you feel that pulse, and they probably won't have a pulse because you cannot beat a ventricle that fast in any functional capacity. So I hope this little quick review of VFib helps you. If you didn't and you have any questions about VFib, feel free to ask in the comments. And if not, thank you so much for watching. Feel free to subscribe to the channel if you enjoy this content, like this video if you like it, and thanks for watching. We'll see you on the next ECG. Have a great rest of your day.